A very good afternoon to esteemed faculty members and dear friends in the audience. So I'll be talking about a very simple history-based case on steroid-induced glaucoma. So typically when a patient comes to my OPD and has high intraocular pressures and I want to rule out steroid use, this is my typical questionnaire when I'll ask them if you have any other history of any eye infection for which you have used medications, any history of over-the-counter medication, any asthma, nebulizer, inhaler, any skin issue for which they are using cream, any scalp problem, any illness for which they are on long-term medication, or any desi dawai, churan or pill without a wrapper that they are taking without, without a physician's consult, or any other problem. So this is my typical questionnaire. So coming to my case, he was a 34-year-old male badminton player, was diagnosed with ulcerative colitis at the age of 31 years. He was started on Predmet 60 mg, used for 8 weeks, started complaining of cloudy vision, when on examination was found to have intraocular pressures of 52 and 48 with a healthy optic nerve head. Responded well to medical management. Within 4 weeks of starting anti-glaucoma treatment and tapering steroids, he was maintaining intraocular pressure in mid-teens on 3 medications. A year later, he developed itching, redness, was treated with loteprednol LS, BD for 2 weeks, again gave a history that his IOP shot to 32-34. In both eyes, again steroids were tapered, medical management again increased, eventually again got the IOP back in mid-teens. The patient presented to me for the first time in June 2021 for a second opinion and also with complaints of itching and watering. IOP was well controlled on brinzo, and travoprost. The patient was started on lubricants and olopatadine. July was all okay. In October, the IOP again was okay. However, the patient was complaining of increased allergy. I offered him a short course of FML BD for 7 days only, but patient was obviously very educated, well aware, and said, no, I would bear the allergy, but I do not want even a short course of steroid. I said, fine. I also started the patient eventually on cyclomune 0.1%. Patient then again came on 12th of November. IOP was okay. Allergy had even aggravated further. He had a tournament to attend and wanted immediate relief anyhow. So I gave loteprednol, TDS on day 1, BD on day 2, OD on day 3, and LS on day 4, day 5. Only 10 drops over the 5 days. 17th November, IOP had shot up to 26. I could not add any more topical medication. Patient was allergic to brimonidine. Then on 25th November, again the IOP was still higher. I was still observing that, since the disc was healthy, IOP that day was 25-26. 4th December, the steroids had already been stopped about 10 days back, but the IOP today was 30-32. I could not explain. I asked my questionnaire again if there was something else differently that he was doing. So he said nothing, and then 4th December night, he went back home and called me that, ma'am, I was applying clobetasone cream to my son for an exacerbation of atopic dermatitis. Is it because of that? So here was the clinching diagnosis. So he was having transcutaneous absorption while he was massaging the clobetasone onto his son's skin. So I asked him to stop immediately and get the IOP checked for son also. So 14 December, eventually I followed up when the steroids when he stopped using that cream. The IOP came back to normal. It took about 6 weeks for the effect to wane off. So this case added to my questionnaire list that I also have to ask if you are applying steroids to somebody else in your family. Thank you.